Christina. This is Al. He's been telling me for a decade that he's practically a doctor. So we decided to test that theory. Seriously, though, he is not a doctor. He's an idiot. And honestly, medicine is constantly changing, so I'm probably wrong too. The point is, this is not medical advice.
So, what do you got for me?
I have an 86-year-old male patient, 94 kilos. Came in with sepsis, pneumonia, no allergies noted. So he was admitted 2 days ago to the ICU. I know you're usually in the ER, but welcome to the ICU today.
Absolutely, I can handle all of these things. I'm a doctor.
Yep. And most doctors can just float wherever.
Exactly, that's what we're known for. We don't really do specialties.
It's all the TV shows.
Yeah, that's what I heard. I also can investigate crime scenes in case you're curious, but that's it's more of a side project. So anyway, so sepsis, you were saying, ICU patient.
So admitted to the ICU 2 days ago for septic shock from community-acquired pneumonia.
Mm-hmm.
Has a history of obesity. He is a smoker. Had a hernia repaired 10 years ago. Hypertension and a cabbage about 15 years ago.
How old is he?
86.
Okay.
Still kicking it.
I'm not loving his odds.
I mean, I wasn't loving them the moment you walked in the room, but that's fine.
Guess who pulled the short straw? All right, go ahead.
Heart rates have been 126. He is in sinus tach. Blood pressures have been 115/72. Respiratory rate 22. Tmax at 99.5. His O2 sat has been 96%. From a neuro standpoint, he is sedated. Pupils are equal and reactive. He's on propofol at 40, fentanyl at 150. His cardiovascular standpoint, pulses have been +1s. Throughout, he is pale, dry, cap refill is about 4 seconds. He's on vasopressin at 0.03. Respiratory standpoint, he's got a breathing tube at an 8.5, breathing tube taped at 22. His vent is in SIMV mode. We're at FiO2 of 50%, tidal volume of 700, PEEP of 8, pressure score to 10. He started bleeding from the nose and mouth this morning.
That's not great.
Nope, usually not a good sign.
So.
GIGU, his abdomen is soft, non-tender, non-distended. He does have good bowel sounds. He had some bloody stool this morning. His urine output is down to 10 mLs per hour for the 24 hours. And he's on D5NS at 210.
Come on, a good doctor couldn't save this guy.
Yes, we can. Come on, you got this.
Of course I can. I'm a doctor. Go ahead. I'm just listening to all this stuff. Like, I know just... Anyway, please go ahead. Let's focus here.
From a musculoskeletal standpoint, everything's intact. He does have a skin... most things are intact. He has a skin tear to his right arm. It's dressed with Methylex. Looks fine. He's on vancomycin and cefepime from an infection disease standpoint. His home meds are aspirin, Plavix. He takes a multivitamin, and he's on lisinopril. All of those are on hold currently. He's got a right IJ triple lumen central line, right radial art line, and 2 PIVs. We did do some labs this morning. His CBC, I'll just give you the abnormals. His WBCs were 32, platelets 45, H&H is 25 and 7.6. Coags, his PT was 65, INR 5.6, APTT 79, fibrinogen 196, D-dimer 642, and on his CMP, his glucose was 462, BUN 42, and creatinine 2.
Just what I expected.
Come on, we can save it.
No. Yes, of course we can. So let's... We don't do this in front of the patient, right?
Nope.
During rounds.
We're outside the room.
So let's... All right, so we've got community-acquired pneumonia. We've got breathing issues. We're bleeding just randomly from all sorts of orifices.
Yep.
So let's start with... Did you already have him on a broad-spectrum antibiotic?
Yes, that's the vancomycin and the cefepime.
Okay, so he's been on that. He's been on that since he got here.
Mm-hmm.
Okay. We know he's still got pneumonia. And the breathing, what did you say about the breathing?
So he's got a breathing tube in.
Right.
It's doing the work. Settings have been at a stable level for the last couple hours. His blood gases have been improving.
Okay. So let's see what's going to cause him to bleed internally. Because he's bleeding internally if it's coming out of orifices, right? So in the movies, once you cough blood, that means you die. That's what you do just before you give your last words.
It'd be really bad if that happened in the hospital.
Yeah, I mean, it would be cool if they got to give some epic last words, but I don't think that's what's going to happen here. He's all vented.
I mean, he can't speak
Right.
currently.
He's vented and sedated, so
Yeah.
there's no cool last words coming out of this guy. So other than like, I assume that that's not probably, it's not appropriate. Can you, professionalism, please.
My bad.
Yeah.
I'll work on that.
Yeah, Jesus. So let's, you already did the blood panel.
We did labs. HH, would you like to give some kind of blood product?
What stops internal bleeding? Can we get a surgery consult?
Sure.
We don't know what they need to look at though, do we?
They might want to know why you're consulting them.
Because he's bleeding internally.
Okay. So you want like a GI consult?
Yep.
His gut?
The GI was. What did you say about GI? The bowels were distended, right?
No, his belly is soft, non-tender. He is stooling, but the stool had blood in it.
Okay, so we're picking up blood somewhere along the line. And he's also coughing it up. It came out of his nose and mouth?
Yes. During oral care.
Okay. Is that, like, was that from, like, opening, like, inside the nose and mouth, or was that coming up from inside?
I mean, it's hard for me to tell. I know when I went to clean his mouth this morning, there was some bleeding, and it looks like it's pooling in his mouth.
Okay. And what are we doing to make sure he doesn't drown in his own blood?
Suctioning?
Okay, that's already happening, right?
Suctioning, yeah.
Okay.
His ET tube secretions have been a little bit pink.
Yeah, so he's bleeding inside. I definitely know what to do about internal bleeding.
So if he's bleeding inside, like, are you concerned that there's like a big pool of blood in one place in his body that is coming out of all these different places?
I'm concerned that he's losing blood, and we need that. I remember that from medical
So
school.
should we give some back?
No, because we need to stop. We need to make him stop bleeding.
Okay.
Inside.
Do you want me to like plug his nose up?
Yeah, let's just go ahead and cover all the holes. Just stick them all up. They'll stop bleeding eventually, right?
It's going to be challenging with the rectal bleed, but that's fine.
Well, do what you can. No, don't do that. What we're going to do instead is I don't know how to treat internal bleeding. What I mean here is, nurse, here's an opportunity for you to show if you've been learning things. How would you recommend we treat internal bleeding?
Well, I think that his coagulation is probably a problem. Also, he's been bleeding for a little while now. So
he's low on blood.
Low.
So we got to do two things. So first, yes, let's put more blood in him, and let's give him a med that helps with blood coagulation, because you stop bleeding. You always stop bleeding eventually, right? But you stop bleeding and live because your blood clots. So we need something that helps clot blood, which should help it stop for whatever it's bleeding inside.
Okay.
So let's use the medicine that does that. That helps with that?
Sure.
Do we have a medicine that we use that helps encourage blood clotting?
Not really. We have a lot of medicine to make it thinner and not clot.
We
Not
need
really.
fatter blood, not thinner blood. You
want me to give him some lipids? Like, that's some fat right into the blood vessel?
just inject it, just central line, just straight.
Let's talk to pharmacy and see what we've got available.
Yeah, I guess we're just gonna do that. Let's go ahead and notify next of kin. This is.
Oh no! I don't think I've ever seen you throw in the towel this early.
It's just stop and kept going. I'm like, I'm a doctor. You can't say them all.
Oh, that's great.
I don't. If you have any other suggestions,
I think what you meant is, I'm a doctor and I can't save any of them at all.
Excuse me, professionalism.
Sorry.
But no, that's also accurate. Do you have any recommendations? I'm open to any kind of ideas that you might want to share.
I think I'm gonna order some blood.
Yes, do that.
Just like full blood, like maybe some packed red blood cells, because oxygen delivery might be a problem. I have lots of suggestions. I feel like we can talk about later, but I can't.
That's okay. I'm pretty sure that once we give him more blood, he'll be fine. Everything else is fine here. This patient's going to be fine. Everyone listen. He's going to be fine. Next patient! Yeah, no,
This one,
Nope.
definitely dead.
Nope.
I'm sorry.
I try to listen as you go through this list of stuff, and and I do. I mean, I am focusing, but I can absolutely tell there's a moment. I'm sure if you guys are watching, you can tell there's a moment where my eyes glaze over, so I'm like, I no longer am taking any of this.
Was that with the ventilator settings when I got to respiratory?
No, actually,
earlier?
I have children. I've been married a long time. I'm very good at tuning out stuff that doesn't matter. So I kind of let some of that stuff slide by me. But when you get to like his levels or on anything, I'm like, I try to focus in on those because I'm hoping, well, if I don't get it this time, maybe I'll understand what it is next time. But no, they just kept going and kept going and kept going, and I'm like, WBC stands for white blood count.
Yes.
See,
You're learning something.
I'm starting to put some of this stuff together. I don't know what a good white blood count is. I just figured what the acronym was, and that's as far as I've done. But this one, you just kept going and kept going and kept going, and I'm like, oh god, like 80s. I mean, he was already an old man who was got a bunch of comorbidities. He's, I mean, just all of a fat smoker, 86-year-old fat smoker. And I'm like, and with pneumonia, I'm like, well, he's dead. He dies now. This is how it wrapped up for him.
Not always.
I'm sorry. With a good doctor, it may have been a different scenario. But I was like, I gave up any chance. I'm like, I couldn't even figure out. Was he bleeding internally?
He was bleeding. So he was oozing blood, which is good. You don't want it like squirting out. That's an arterial bleed. That's a problem.
I mean, way to look on the bright side. Oh, you were wrong. Tell me why you were wrong.
I was wrong. Hold on.
Oh, sorry. I just was so excited because
I was wrong. I froze and could not for the life of me think of what medications we give to promote clotting, because in most of my patients, we try to avoid that. Vitamin K and TXA are two of the several medications you can give to promote clotting, and it's usually used in surgery, like after surgery to prevent bleeding.
It sounds like that would have killed him here, though.
So it would have, only because we're dealing with DIC, which is disseminated intravascular coagulopathy.
Oh, yeah, no, obviously.
That makes perfect sense.
Yeah,
right?
no, absolutely. I can't believe I missed that.
In DIC, so, okay, first I want to start with, this was a very complex patient. And even if you had done everything right, like if we do everything right in the hospital, this patient may still not survive. This is a very sick patient, and sepsis is a huge cause of mortality nationwide.
Sorry, I heard that one too. I heard sepsis. I knew enough about sepsis to be like, oh god. And it just kept getting worse and worse. Like, oh god.
So, and that's why I gave you the sepsis from the beginning, and I was like, I really hope you realize that since this is the admitting diagnosis, it's not what we're getting at here. This is not a sepsis treatment. This is actually
yeah, because I would have known what to do with the sepsis treatment.
Pretty sure we did that one a few episodes.
I'm sure we did.
Still have no idea. This is a common complication of sepsis.
Okay.
And other common diagnoses. So this is where your coagulation cascade gets thrown off. So there are a ton of different factors in your body that work together to cause an appropriate coagulation. So your blood isn't so thick that you're getting clots, and your blood's not so thin that you're bleeding. When you're sick, with sepsis especially, this is most common with sepsis, many different parts of that coagulation cascade get affected. And so you have a patient who can clot and bleed at the same time.
Oh, come on. I was never going to save this guy.
You weren't. No. Those of us in the medical community know this exists.
Yes. I'm sorry, yeah. I just think sometimes when the patients are there and there's like, if you just did this thing,
this one thing,
then you could do it. Like, and I might luck my way into that. This one there was just
you weren't lucking your way into any this.
Nope.
I knew was going to be a challenge. But it's a challenge.
I was going to kill them harder than normal.
Harder than normal. They're more dead than normal.
They are extra dead.
This is a difficult thing to treat in medicine too. Like, you can identify it, and we're just like, well, I guess we're going to keep doing this and support them until we can get them past it. The goal is to fix the sepsis.
Oh,
and then this stops.
So you fix the sepsis and keep them alive until this thing resolves itself?
Until it can be
or
fixed.
It doesn't?
And so our goal is to support them, right?
Gotcha.
So I would not want to give vitamin K or TXA or any of these other clotting promotion factors, because our bleeding is a goose. Like, he's bleeding from the nose, the mouth, the rectum. Like, okay, that's not great, but I can fix that. I can give blood.
Gotcha.
So definitely replacing blood as they need it. His H&H was 25 and 7.6. That's not terribly low, especially in adult patients. In my world, that's like super low, but low enough.
Tell them what your world is real quick.
Pediatric cardiac ICU. So I'm I had to get this reviewed. Thank you to Jen Sterling for reviewing this for me so that all my adult numbers would make sense, because she gave me that fentanyl dose and I was like, holy crap.
Yeah, that's what I was thinking too.
Big dose for tiny babies. But giving blood products to support the bleeding that you're having those blood products on hand. Platelets of 45. Anything under 100 is typically low. Sometimes you can tolerate that if there's not active bleeding, but especially if you're actively bleeding, anything under 100 we want to get platelets for. Platelets are going to promote clotting in your blood, but without, like, vitamin K is going to, like, clot, and this is going to, like, oh, hey, you have platelets now that can clot in these places that are bleeding. Mucosal areas are high risk for bleeding because the tissue is very thin. There's a lot of capillaries there. So that's why you'll see a lot of bleeding in the mouth, in the nose, in the rectum.
Gotcha.
Because it's very thin-walled mucous membranes.
Okay, because I was thinking that he was bleeding, like there was something inside.
It's like gushing blood.
I don't know about volume, but there was blood coming out there, and then it was transported and coming out the bladder that way, but that's not what happened.
And with DIC, it's not like you've sliced an artery and you just got like blood coming out kind of thing. It's gonna be this ooze that's like happening just in a really weird way. You're like, well, I wasn't aggressively doing oral care. Like it's just pooling there.
Gotcha.
So that's kind of how you can know, like this bleeding doesn't add up. It doesn't make sense. So you may need to start heparin, which seems counterintuitive to this patient that's bleeding. Now I would probably want to give my clotting factors first. Platelets and FFP is the other one, fresh frozen plasma, because that's going to have fibrinogen in it. That's going to like help promote blood clotting and to stop the bleeding. So I'd probably give those first and then start some heparin because of the risk for clotting.
Gotcha.
And you can have DIC patients who present mostly with blood clots and DIC patients who present mostly with bleeding, but there is a possibility for them to have both.
Gotcha.
So you may need to start some heparin to make sure that they don't clot, because if they clot, you're going to get a pulmonary embolism, a stroke,
right,
cardiac infarction, like myocardial infarction.
And how do we treat sepsis again?
So with sepsis, fluid boluses, they're going to need a lot of fluid support. He's on the vasopressin to support blood pressure, treating the infection.
Okay.
Like you need to get rid of the infection, and everything else is geared to supporting that patient until you can clear the infection.
So that was why, but we was already on the broad spectrum.
He's already on antibiotics. I forgot to tell you, we sent all the cultures, like we're waiting on result, that kind of stuff.
Okay.
We're doing all of this stuff from an infection disease standpoint.
So the problem here wasn't the sepsis. Well, I mean, it was the sepsis, but
I wrote the case, so no, it wasn't the sepsis.
Well, I mean,
we were fixing that.
The sepsis is a problem, but that was being resolved. The problem here
this
was
is the side effect of
treating the side effect. Okay. I mean, in 2 more patients, you can give me this exact same thing, and I'll still die.
Maybe not as smart.
But hopefully, just mostly dead.
Just as a recap, we had consult surgery, consult GI,
I
pharmacy consult, and then based on my recommendation, give blood.
I had no idea what to do. Even for me, I was lost. Not a doctor.
Oh, and one of the other things, oxygen therapy, making sure you optimize their oxygen support, because if your blood cell counts are low, you're going to have a problem. And in sepsis, in septic shock, any kind of shock, the problem is oxygen delivery to your tissues. So optimizing that oxygen delivery until they can get past this to make sure that your tissues are getting good oxygen will help prevent organ failure.
Cool. Okay, well, folks, that is going to do it. There's another dead person on my record.
Check the links for more information. Thanks again to Jen Sterling for making sure my adult numbers make sense.
And as a reminder, this is not medical advice. She is actually a nurse. I'm not actually a doctor.
Still not medical advice.
Still not medical advice. If we got anything wrong, let us know in the comments. We'd love to figure it out. Again, we're just doing the best we can here, so don't non-medical advice. Like, subscribe, or there's a bell somewhere to do things. I don't know. Thanks, everybody.